So first, thank you so much, Robert, for the introduction, and I can't tell you how happy I am to see all of you in person. And for those of you that do not know, I'm also very passionate about contact dermatitis, and in fact, this is how I met Eric for the first time. When I did my second residency in the United States, I actually was the last fellow, I believe, that Francis Storrs had in Oregon, just to learn patch tests in the United States. So I was scratching my head a little bit about how should I give pathogenesis of non-atopic forms of dermatitis when we do not know much about the pathogenesis of these forms. So I'll give you an overview, and maybe a lot is what I think may be the pathogenesis, but a lot of work needs to be done about these. So my disclosures, they are all related to atopic dermatitis primarily, or alopecia areata, definitely not to the other forms of atopic dermatitis. So what are the non-atopic forms of dermatitis? And again, this is my view, and I'm not talking potentially about all of them. I don't have time today to talk about all of them. I'll cover today facial eczema, irritant and allergic contact dermatitis, chronic hand eczema, seborrheic dermatitis, rosacea, and there are many others, urticaria, stasis dermatitis, and many others, but I particularly talk about the ones that we do see much more in atopic dermatitis patients. So atopic dermatitis is a disease that we definitely know now the pathogenesis, and that led to all the therapeutic development we now have in atopic dermatitis. So we know that atopic dermatitis has two pillars. On one hand, we have vast immune abnormalities with increases in type 2 molecules or cytokines such as IL-4, IL-13, IL-31, IL-22 that belongs to the Th22 pathway. And in the chronic stage of the disease, we also have interferon gamma. And we have also a very wide barrier defects that allow penetration of irritants, allergens, and microbes, creating the disease phenotype. And we know that there are also a downregulation of filaggrin, loricrin, other terminal differentiation molecules, and lipids. Now I'll start with facial eczema, and facial eczema is kind of a mixed path that has a variable pathogenesis dependent on the primary condition and the allergen. So on one hand, we have irritant contact dermatitis that presents an innate immune phenotype, but also is Th1 and Th17 driven. We have allergic contact dermatitis that we showed, and I'll show you the data, presents a Th1, Th17 profile for metals such as nickel, and Th2, Th22 phenotype for rubber and fragrance. And atopic dermatitis that also has facial involvement presents a Th2, Th22 profile. And we have seborrheic dermatitis that we still do not know the pathogenesis, and multiple cytokines, both innate and other cytokines, have been proposed, and we still need to understand it better. And rosacea, the same. We think it may be having some Th17 involvement, but we really do not know well. And ideally, of course, we should direct the treatments to the primary immune abnormality. And of course, we need to remove the allergen or the irritant when we are talking about ICD or ACD. So what is the pathophysiology of irritant and allergic contact dermatitis? And you'll have another talk on irritant contact dermatitis and one on allergic contact dermatitis. But irritant contact dermatitis primarily involves innate immunity, with involvement of IL-1 beta, IL-6, IL-8. And allergic contact dermatitis lesions are secondary to activation of specific T cells specific to the antigen at the site of contact with the allergen or hapten. And usually that's induced in a previous contact. And ICD reactions are mandatory. They usually are the first step that we need actually in the activation process of ACD. So for an ACD reaction to happen, you actually need first to have an irritant reaction. And we know that patients with atopic dermatitis are much more readily sensitized and show increased ICD and ACD responses, depending, of course, on the allergen. For example, fragrance responses are much more prevalent in patients with atopic dermatitis. So what is the pathophysiology of allergic contact dermatitis? When we did our study in contact dermatitis, there were only murine models that were available at the time, and they suggested the primary Th1 pathogenesis and later also Th17 pathogenesis with increases in interferon gamma and IL-17, and those studies were with very strong sensitizers such as DPCP, DNCB, and we need to remember these allergens are not really relevant to our human patients. And the reason being that in mice, the weaker or clinically relevant allergens such as nickel, cobalt, fragrances, and others completely do not induce any responses in mice, so we were unable to study these in murine models. So together with my Israeli colleague, Avner Shemer, we embarked on a study that intended to characterize the specific immune responses to different clinically relevant sensitizers in human skin. And this is the study. It was a very tough study to do. In fact, I flew to Israel for a week, and we did the study together in his clinic. And he already knew the patients and which allergen they are allergic for. And we started with 30 patients that we patch tested them for the 15 most common North American contact dermatitis panel. And we used petrolatum occlusion as control. We obtained at the end 24 patients with positive reactions that we scored like we usually score in patch tests, +1, +2, +3. And we biopsied the responses, and also we biopsied uninvolved skin and, of course, the petrolatum that was control. We first found that these responses were characterized by a very large cellular infiltrates, particularly T cells, but not only T cells, also dendritic cells of different flavors of dendritic cells. And here you see that all of them have really major cellular infiltrates of T cells, nickel more than the others, but all of the allergens had a large cellular infiltrates. And we also saw that under the vesicles, you could see these aggregates in which you saw T cells and dendritic cells, and we call them ISALT, similar to Kenji Kabashima's work in mice. And we also stained for them really nice aggregates in which T cells and dendritic cells are exactly under the vesicle that is created by the allergen. And interestingly, we did genomic studies using microarrays, and we expected to find a common phenotype of all the allergens, but this is not what we found. We found actually that the common phenotype was very small. It included only 149 differentially expressed genes. However, different antigens such as nickel, fragrance, and rubber, as shown here, they had very different phenotypes. For example, nickel had Th1, Th17 involvement, whereas fragrance had Th2 and Th22 involvement, and this sounds similar, right, to atopic dermatitis. And this may be the reason why patients with atopic dermatitis, they have many more fragrance responses. And rubber, also more prevalent in atopics, had increased Th22. So different allergens induce different T cell polarization, unlike the studies done in mice. Nickel showed Th1, Th17 responses, fragrance and rubber, Th2, Th22 immune polarization. And I think this data helps a little bit to explain the observations linking ACD and atopic dermatitis. Patients with atopic dermatitis, they have a higher rates of allergic contact dermatitis, but the responses don't have as much intensity as if you do not have atopic dermatitis. Now let's move on to chronic hand eczema. That's another dermatitis, again, more prevalent in our patients with atopic dermatitis. Depending on different studies, you see different rates, but I would say it's up to 10% of the population, give or take. It's the most common occupational disease, and more than 1/3 will have moderate to severe disease or persistent disease, often chronic, and much more prevalent in females, about a double in females. And it's usually a hybrid eczema. It's hard to say that it's either irritant contact dermatitis or atopic dermatitis. or allergic contact dermatitis, many of the patients will have more than one. And there is a huge unmet need for better treatments for long-term disease control in these patients because they always come back when they use topicals. And currently, as we know, no FDA-approved treatments for CAG. There are some treatments going into chronic hand eczema. So many of them are irritant, about 80%. Less than 20% are patch test positive. Many of them are atopic, nummular, some of them vesicular, and some of them are frictional or psoriasiform. Some relevant allergens, and I'm sure you'll hear more about this, but metals, rubbers, preservatives, fragrances, and plant allergens. And some examples, this is a very severe case. And the pathogenesis, again, is variable. Again, multiple causes, and it's always dependent on the primary condition and the allergen. Again, irritant contact dermatitis is innate immunity and Th1, Th17. Allergic contact dermatitis depends on the allergen, Th1, Th17 for metals, Th2, Th22 for fragrance and rubber. And AD is Th2 and Th22. So we need to think about that when we think about treatments for these patients because it's not one size fits all for these patients. So again, the treatment has to be directed towards the abnormality, and you do need to think about that and do patch tests in these patients as well. So I always like to get back to how did we increase the understanding of diseases like psoriasis first and then atopic dermatitis that led to these amazing treatments we now have for both of them, particularly for psoriasis, but now also for atopic dermatitis. So it was through bench studies of pathogenesis with skin biopsies and blood, leading to clinical trials with targeted treatments that also had profiling of skin and blood. And of course, we needed multiple cycles to get to that therapeutic generation. And both successes, but also failures, really helped us frame the direction, the therapeutic direction for these diseases. And we really need the same for the facial dermatitis and also for chronic hand eczema. And how are we going to get there? So we need biomarker studies in hand eczema, and they are harder to do because skin biopsies are really tough to do in these areas. So I think we need to incorporate non-invasive biomarkers, tape strips, to study chronic hand eczema across the phenotype. And actually, Robert and I are doing such a study that is ongoing. So hopefully, later this year, we'll share some data. Now, seborrheic dermatitis, it's a chronic inflammatory skin disease, super prevalent, characterized by scaling, erythema, pruritus. Occurs in an area of high concentration of sebaceous glands. And it's involving the face, the scalp, the chest, the back. The epidemiology is variable depending on the study you read, but the prevalence that I found for the United States is 1 to 3%. My own feeling is that it's more prevalent, at least in my own clinic, and some studies estimate as high as 10%, and worldwide prevalence about 5%. And we all know that up to 50% of the population have dandruff at some point, and this is also on the spectrum of seborrheic dermatitis. It's most commonly occurring during very early infancy, and then it goes away, but then puberty and 40s, 60s. And there is an increased incidence in patients with neurological diseases and HIV-positive patients. Also important to note that it's highly increased in prevalence in African Americans, and apparently it's among the 5 most common diagnoses in Black patients. And also it can present in Black patients with hypopigmentation, so important to remember that. The pathomechanisms are all over the place from the studies I've looked at, so a lot is still unknown about seborrheic dermatitis. Sebaceous glands are involved, and lipids are pro-inflammatory, and many cytokines were involved, innate cytokines, potentially Th17, but I've seen also Th2. There is a skin barrier disruption, and definitely we need more studies. In my department, Benjamin Unger is doing studies now on seborrheic dermatitis, and he also is engaging in some novel treatments for seborrheic dermatitis. So one of the most common inflammatory skin diseases, especially in patients of color, currently really minimal investigational therapies. Crisaborole and roflumilast studies, both anti-PDE4, show efficacy in preliminary studies. And safe, effective treatments currently are completely lacking, particularly for patients with moderate to severe seborrheic dermatitis. Rosacea, another disease that a lot is unknown, again, because it's on the face, hard to do biomarkers in this area. A chronic inflammatory disease, about 2% prevalence in the general population, primarily affects the central face and the eyes. And it's characterized by persistent erythema, papules, pustules, telangiectasias, and at the extreme, phymatous changes that are more common in men. And many will have ocular features, and definitely we need to think about that and send them to an ophthalmologist and treat them. There are several classifications. The historic classification classified it into 4 subtypes: erythemotelangiectatic, papulopustular, phymatous, and ocular. And recently, there is also a new diagnostic paradigm that was introduced in 2017 because of the variability and the fact that there are so many types. And the new diagnostic paradigm suggests either of the 2 features as diagnostic, either persistent centrofacial erythema with periodic intensification by potential trigger factors, or phymatous changes. Now, when we look at how many patients have rosacea and how many are untreated, it's actually more than psoriasis, believe it or not. So it's something to remember, and patients are not happy about their treatment. Current FDA-approved treatments, we need to think about treating the inflammatory component or the erythema. So inflammatory first-line treatments, azelaic acid, finacea. And as you see, it's marginally or modestly improving the disease. Topical metronidazole, a little bit older treatment. Now we have a little bit better treatment, Soolantra, ivermectin, 1%. This is currently the best treatment available, and also the safety is the best. And minocycline foam, oral doxycycline 40 milligrams, Oracea, and Soolantra, again, probably the most efficacious treatment available at this time. Erythema targeting treatments, Mirvaso or brimonidine, and also Rofade. And we need to remember that some of them are treating the disease but are causing some side effects, including irritation. And in rosacea, patients do not tolerate irritation that well. So we definitely need a better treatment that will not cause irritation. So burning, stinging, and irritation. And we also need to remember that some of these patients are also allergic to propylene glycol that also is in some of these treatments. Metrogel also causes irritation. So Soolantra also has the best profile in terms of the side effects, the fewest side effects as well. And again, irritation with Mirvaso and Rofade as well. In terms of pathophysiology, still under investigation, elevated Th1 and Th17 pathway genes were proposed, particularly in the papulopustular rosacea, but also in the erythema telangiectatic rosacea and the phymatous. But again, we need to study it some more. Innate immunity is also involved. Multiple cell types were postulated as being involved. Increased Th1 and Th17, Demodex and TLRs are also involved, but we need more studies in rosacea as well. In terms of treatment, oral apremilast showed a potential promise in 10 patients, a very small study, pilot study, a trend towards overall improvement and significant improvement in the erythema, but we need more studies so that we have more treatments. So to summarize here, one of the most common inflammatory skin diseases, we really have a pathogenic-based, I mean, we are lacking pathogenic-based treatments, and Soolantra is probably the best currently used treatment, but we need better treatments that can modify the persistent erythema. So with that, should I take questions now or at the end? Oh. So thank you so much.